Welcome to Lecturio Podcast. Here we break down complex medical concepts into clear and concise discussions that reinforce your understanding.
I'm ready. So today let's talk about something practically everyone experiences. A runny, stuffy nose. But it's not always just a cold, right?
Exactly. We're diving into rhinitis, which is the inflammation of that nasal mucosa. And you're right, it's a broad term. We generally classify it into three big buckets: allergic, non-allergic, and infectious.
Okay, 3 buckets. Let's start with the most common one. I'm guessing that's infectious rhinitis.
You got it? Infectious rhinitis is what we all call the common cold, or an upper respiratory infection. It is, by far, the most frequent form, especially in kids. We're talking an estimated 6 episodes per year for a child.
6? Wow. And it's mostly viruses, isn't it? Like rhinovirus?
Precisely. Rhinovirus is the main culprit, but you also see coronaviruses, influenza, adenovirus, the usual suspects. They use a specific host receptor, intercellular adhesion molecule 1, to sneak into our nasal cells.
And once they're in, they just wreak havoc, triggering all that inflammation and mucus production.
That's the process. It's a cascade involving pro-inflammatory cytokines, leading to all those classic cold symptoms: congestion, sneezing, and that lovely rhinorrhea.
Okay, so that's the common cold. What about the second bucket, allergic rhinitis? This is the one that gets people in the spring and fall.
Yes, and this one has a completely different mechanism. It's a type 1 hypersensitivity reaction. Think of it as your immune system being a little dramatic.
Ha. Dramatic how? What's the pathophysiology there?
It's all mediated by immunoglobulin E, or IgE. The first time you're exposed to an allergen, say pollen, your B cells produce IgE antibodies specifically for that pollen. These IgE antibodies then attach themselves to mast cells in your respiratory mucosa.
So they're just waiting? Like little landmines?
Perfect analogy. They are primed and ready. The next time you inhale that same pollen, it connects those IgE antibodies and boom! The mast cells degranulate, releasing a flood of histamine, leukotrienes, and other inflammatory stuff.
And that flood is what causes the itching, sneezing, and watery eyes. That makes so much sense. This is also where we see those classic physical findings, like allergic shiners, right?
Exactly. Those dark circles under the eyes, the allergic salute, where kids push their nose up, creating a little crease, even Denny Morgan lines under the eyes. They're all telltale signs of atopy.
Fascinating. Okay, we've covered infectious and allergic. What in the world is in the third bucket, non-allergic rhinitis?
This is the interesting one. It's a bit of a catch-all category. The core issue is increased blood flow to the nasal mucosa, but it's not triggered by an allergen or an infection.
So it's not really an immune reaction in the same way? What kind of things can trigger it?
It's so varied. You have rhinitis medicamentosa from overusing decongestant sprays. There's drug-induced rhinitis from things like antihypertensives or NSAIDs. There's even gustatory rhinitis.
Wait, gustatory? From taste?
Yep. You know how your nose runs when you eat super spicy food? That's it. It's a cholinergic response to stimulating receptors in your palate. There's also pregnancy rhinitis due to hormonal changes, and even something called honeymoon rhinitis.
Okay, I have to ask. Honeymoon rhinitis?
Yes, it occurs following intense sexual excitement. The pathophysiology for these non-allergic types is thought to be an imbalance in the autonomic nervous system, a decrease in sympathetic activity, which causes vasoconstriction, and an increase in parasympathetic activity, which causes vasodilation. So a key difference here is that with non-allergic rhinitis, you don't typically see the prominent itching and sneezing that you get with allergies. It's more about the chronic congestion and drainage.
That's a great clinical pearl. So when a patient comes in, the diagnosis is primarily clinical then, based on their story?
Absolutely. The history is everything. Is it seasonal? Is it perennial? Does it happen after taking a certain medication or after eating a spicy meal? You're looking for patterns. Physical exam findings support it, but you don't necessarily need a RAS test unless you're really trying to pin down a specific allergen for immunotherapy.
And a common misconception I hear is about the color of the nasal discharge. Many people think green or yellow automatically means a bacterial infection that needs antibiotics.
That's such a critical point. The color can vary in any infectious rhinitis, including viral ones. It's often just the result of neutrophils and cellular debris. We don't jump to antibiotics unless there's strong evidence of a bacterial cause, like a documented group A strep infection.
Okay, let's talk about management. How do we approach treatment for these 3 different types?
It follows the cause. For infectious or viral rhinitis, it's supportive care. Rest, fluids, maybe some decongestants. It's self-limiting.
And for allergic, I assume it's all about blocking that histamine reaction?
You got it. First-line options are antihistamines, intranasal corticosteroids like fluticasone, and decongestants. Allergen avoidance is key, of course. For more severe cases, we might consider immunotherapy to desensitize the immune system.
And for the tricky non-allergic category?
It's all about correcting the underlying cause if you can. Stop the offending medication, avoid the spicy food. If that's not possible, topical antihistamines and intranasal glucocorticoids are often the first-line medical options.
So, to wrap it all up, when we hear rhinitis, we need to think in 3 main pathways. Infectious, which is our common cold. Allergic, which is an IgE-mediated, type 1 hypersensitivity. And non-allergic, a diverse group triggered by everything from drugs to hormones to food, all leading to that inflamed, drippy nose.
That is a perfect summary. By breaking it down by pathophysiology, the clinical presentation and management strategies just fall right into place. Thanks for joining us on the Lecturio podcast. We hope this helps you tackle your next exam question on rhinitis with confidence. Goodbye for now.
Thank you for tuning in. Keep exploring Lecturio's features to strengthen your knowledge and master key medical concepts. See you in the next episode.